All right, it is 1 o'clock, and so I'll go ahead and get started. I think we're waiting on Chairman Cooper. She said she was going to be here. We'll go ahead and get started and with our agenda today. And then in the interest of time, I'll be respectful to our presenters and our committee members as far as moving through the agenda. Didn't actually have formal minutes, but in your packets, in the committee members' packets, we got Representative Harden and Representative Douglas, myself, and Taylor, and we are waiting on Chairman Cooper, who should be here shortly. We had a summary that was prepared from our last meeting, and it just talked about a description of school-based health centers, why they are needed, and I think we'll get some more insight there today from our presenters. And then from Dr. Johnson with her work about making sure that if they are started, that they have a good business model and a sustainability base. And I think we've determined that there is definitely a benefit from these centers, and that we can really see an improvement in both student performance and health from the clinics that we have in our state. I provided, last time we had mentioned we were going to try to have a September 29th meeting that we didn't do, but I had the opportunity to meet with Laura Bray, who is Vice President for Strategy and Knowledge Management for School-Based Health Alliance, and she provided an overview, and this is from a national perspective, and it sort of parallels a lot of the same things we had talked about: benefits, sort of the history of school-based health centers, looking at a national basis where they are throughout the country, and then also types of sponsorships that 43% of them are partnered with FQHCs, Federally Qualified Health Centers. Some of them are hospital and medical center based, supported strictly from school systems, private nonprofit organizations, and public health as far as the sponsor types. And then just from a national perspective, spent about an hour and a half with her just to sort of get an idea from a national perspective of how school-based health centers are handled throughout the country, which was very informative. Okay, that's in for the committee members. It's in this. There's a PowerPoint presentation in there. Okay. Any other comments from committee members? Okay. Okay. All right. We'll go ahead and start with our presentations. We're very honored today to have Dr. Robert Hand from the CDC to present to us. Dr. Hand, I appreciate you taking your time to be with us and give us your perspective, and look forward to your presentation.
Thank you, and it's an honor to be here and to have you all consider the scientific work that we've done on this intervention, which we consider very important. I'm here on behalf of the Guide to Community Preventive Services. I'll describe that project in a few minutes, but we conduct systematic reviews of all available evidence on interventions to promote public health at the community level. And so this is one of the reviews that we have recently completed. I am the leader of the team that works on health equity, which is focused on improving the health of low-income and minority populations who have challenging issues with regard to access. And we've also looked at early childhood education, kindergarten, dropout prevention, after-school programs, and we have other things in the works. How do I make this move here? It's important that you recognize that the work I'm going to be talking about does not represent an official statement of the work of the CDC. And the guide that I am an employee of produces systematic evidence and is in no way intended as a mandate either for action or spending, but simply to provide the best available evidence for decision makers and stakeholders so that you can make informed decisions about what programs you choose to support. And again, our focus is on public health. There are other outcomes linked to these school-based health centers. So the theme of my presentation is that our task force, the Community Preventive Services Task Force, recommends both the implementation and the maintenance of these school-based health centers, particularly in low-income communities. And the evidence that I will show you, it shows improved health outcomes of multiple sorts, improved vaccination coverage and preventive services, lower incidence of asthma, fewer emergency department visits and hospital admissions, increased use of contraceptives among females, increased prenatal care and birth weight among females, and better health risk behaviors. Also, as you noted, there are educational benefits, improvements in school performance, in grade promotion, and in high school completion. We look at these educational outcomes because of the extensive evidence that educational outcomes are themselves associated with long-term health benefits. The Community Guide has been around since the late 90s, and as I noted, we conduct systematic reviews of all the evidence on different public health topics, motor vehicle safety, tobacco control, diabetes, sexual behavior. In my case, I've worked on alcohol, I've worked on juvenile violence, and for the past 6 years on health equity. Our goal is to accumulate all the available evidence, to weigh this evidence by a systematic approach. When we find something beneficial, we also look at the economics of these interventions, and then we indicate what are the gaps in knowledge so that other researchers can use this information to conduct further research. Again, our goal is to provide evidence for policymakers and decision makers, and we are led by a task force called the Community Preventive Services Task Force. These are non-federal, independent, nonpartisan experts from multiple fields of public health around the country. There are 15 of them. They are appointed by the director of the CDC, but they are not employed by the CDC, so the independence of this body is something we regard as very important, and they serve without compensation. We at CDC are the research staff that take direction from this task force. This is how we define school-based health centers. I don't have to read it word for word, but these are systems of health services provided to students at schools, any age from K through 12. They're either school-based or school-linked. The critical piece is that they must provide primary health care. They may also provide other forms of care, mental health care, social services, dentistry, and they often provide health education. So they have to at least have one primary care provider. They may also have other clinicians responding to the other services they may provide. They need not be available in all school hours, and some are only available, they need not be available every day either. Parental participation, consent is always required in these programs, and sometimes services are provided not only to the students themselves, but to school staff, family members, and other members of the community. The basic question, we're asking two basic questions. One, how effective are these programs in serving whole student bodies? And then among those who use these programs, how effective are they? If you find a program that only serves one student, but it's 100% effective, that's not very useful. You want both reach and effectiveness in the programs that we look at. So we look at both kinds of evidence, and there are different kinds of studies looking at these, both the whole school and the users of these programs. This is the team of researchers that I work with. A number of us at CDC, 2 members of the task force work with me. There's a liaison member from the American Public Health Association, a librarian, partners around CDC, and a lot of external partners as well from NIH, academia, and other institutions. When we develop these reviews, we develop what we call an analytic framework. It's our working hypothesis for the way we think these programs might work. I have a pointer here. Let me see if I can use it. It's a long way to the screen there, but on the left, you can see the centers themselves, which lead to several intermediate outcomes. The red boxes are what we call recommendation outcomes. They're outcomes that we consider criterial when we make decision as to whether these programs work or not. They're either health outcomes or immediate causes of health outcomes, so we consider them primary decision makers in figuring out whether these programs work or not. So the school-based health centers lead to health education. They're commonly associated with great satisfaction and comfort among the patients, the students. There's an increased receipt of recommended services, including immunization, increased access to medical care, which is often problematic for low-income students, and there's often increased earlier diagnosis. These lead to reductions in health risk behavior, including teen births, increased and more rapid diagnosis and treatment, an increase in the proportion of students who have a place to receive regular medical care, and there are also further downstream outcomes, improved academic outcomes, reductions in sickness and absence from school, and improved long-term health benefits as well. And ultimately, our goal, which is what we call health equity, the improvement of the health and of low-income and minority children. We also, so we develop these scheme, and then we look, insofar as the evidence is available, about the logic and validity of each of these links. I can't see this very well. This is a very brief summary of our methods. So we go and collect all the available studies that have been conducted on a particular intervention, in this case school-based health centers. We found in this case there were 44 that met our standards. We then dissect each one. We evaluate it on the basis of what was the design, a good design in order to make inferences that we want, and how well was that study carried out. Then we look at the whole body, what we call the body of evidence, all of these studies together. Was the effect that it was found of sufficient magnitude to be worth considering, and are all the studies looking at the same direction, or are they in scattered directions, so that we're not sure what the conclusion is? Again, the studies we found made two kinds of comparisons. One was among whole schools, some of which had school-based health centers, others of which did not, and we looked at the changes in health outcomes, but comparing the schools with and without school-based health centers. That looks at the whole student body. We also looked within schools at the kids who used the school-based health centers versus those who did not. These methods have different challenges in terms of making inferences, and we took those challenges into account when evaluating the studies. This is what we call the body of evidence. So we rate across the horizontal axis the quality of design in terms of inferring the kinds of outcomes we're interested in. Greatest studies, for example, are randomized trials. Least suitable studies are much simpler comparisons. And then down on the vertical axis, we rate how well each of these studies has been carried out. If a study is what we call limited, has more than 4 penalties, we do not include it in our analysis. So this is probably a bit overwhelming, but I will describe it to you. This is the kind of report. This is slide
16.
16, right, thank you. This is the kind of evidence we produce. On the left-hand side, you can see each of and the outcome we're looking at here is changes in receipt of required immunizations in these settings versus outside of these settings. So on the axis here, you'll see all the studies arrayed, the year they were done, and the baseline rate of immunization for each particular kind of immunization. So there are different kinds of immunizations. Each one is looked at separately. And each of these little triangles is one study. If there's no effect, the study will fall on this 0 line. If there's an increase of immunization associated with the school-based health center, the study will fall on the right side of that 0 axis. And then we sort vertically in terms of what kind of comparison was made. So the top section is school-based health centers versus non-school-based health centers, and below is kids using the school-based center versus kids not using the school-based health center. Overall, it's very clear in this diagram that almost all of the studies except these two fall on the desirable side of the 0 axis. In other words, there's a substantial benefit in terms of immunization outcomes associated with the presence of these school-based health centers. Either the whole school overall benefits or the users benefit, but there's a median, I can't read it from here, 15 point something or other, percentage point increase in the receipt of immunization associated with these. And again, for these populations that are particularly have problems with access, this is a major improvement. I'm going to spare you. We have probably 25 or 30 of these, but I'm going to only show you 3. I'll spare you. This one looks at asthma-related outcomes among these children. Asthma is a fairly common condition among these children. I think something in the order of 7% in this age population. And untreated asthma often leads to emergency room department admissions and hospitalization. So the presence of the school-based health center could be a major source of early treatment, which reduces both hospitalization and emergency department use. So you can see here the top sector is, and in this side, in this case, you want a reduction in hospitalization, so the arrow moves to the left instead of to the right on the previous figure, and that is the way we want the outcome to be. There's a very large reduction in hospitalization for asthma incidents associated with these school-based health center. There's also a substantial reduction in emergency department use, and at the bottom here are reported asthma symptoms reported by families with these children. So again, overall, there's a very large benefit associated with the school-based health centers regarding asthma-related outcomes. One more. This shows changes in the use of alcohol by school students. And again, you want a reduction, so moving to the left of the 0 point. And you can again see that only 1 point on the right side of this axis, which is a direction you don't want, and all the other data points are to the left of the 0 point, indicating again a substantial benefit in the presence from the presence of school-based health centers in the reduction of alcohol use by students. This slide and the next one summarize all of our findings, including the ones that we just looked at. And for each one, we're looking both at the magnitude of the effect, how big is it? Does it merit public health action? And then we're looking at consistency, so are all the studies in the same direction? So you can see that there's a substantial benefit. Am I on the right one here? Oh, I'm sorry. It should be on 17. There's first of all, we found 32% of the studies were of greatest design, and half of them were of fair quality, which is not optimal, but it's good enough to get a strong conclusion. So the first outcome we're looking at is preventive services, for which we found both meaningful effect size and consistency in the body of evidence. Asthma, which I just showed you, again, magnitude of effect is meaningful, yes, and it's consistent across the body of evidence. For self-reported physical health, the evidence was not consistent. There wasn't that much evidence, so we can't draw a conclusion. And it's important to note that absence of evidence does not mean evidence of no effect. It just means we don't know.
It's minimal.
Yeah. Mental health, similarly, we did not have enough evidence to make a conclusion. Misuse of medical care resources, so that would be, for example, when a kid has asthma and is not treated early, he ends up in the hospital or the ER. That's what we're talking about here. Again, big effect size and consistent evidence. Same for a source of regular health care. So kids who might not have had a place for health care previously now have a health care source. And there's a wide variety of reproductive issues that these studies look at. Overall, we concluded no effect, but for some other risk behaviors, also, well, there was inconsistent evidence, no conclusion there. Now, and on educational outcomes, as indicated before, we found both a meaningful effect and consistent evidence across the body of evidence. So overall, the team concluded that there was sufficient evidence of effectiveness for the task force to make its recommendation. Again, we looked at, we have a team that looks at the economics of these interventions. In this case, they found 2 studies that examined the benefit to cost ratio. What is the return of savings that you get by investing $1 in these interventions? And the one study found approximately 1.4 times benefit cost ratio. That is, the return was greater than 1, which is what you want. The second study found a 3-to-1 benefit cost ratio, which is a fairly large ratio. This is the conclusion that our task force reached. Basically, a longer version of what I talked to you earlier about. We recommend, the task force recommends the implementation and maintenance of these school-based health centers in low-income communities based on sufficient evidence in improving both educational and health outcomes. The educational outcomes include school performance, grade promotion, high school completion. The improved health outcomes include delivery of vaccinations and other preventive services, asthma, morbidity, sickness, ER and hospital admissions, contraceptive use among females, increased improvement in prenatal care and birth weight, and improvement in some other health risk behaviors as well. They note that most of this evidence derives from studies in low-income communities, and therefore we expect that these interventions, the school-based health centers, will lead to the achievement of the goal we're interested in, which is advancing health equity. And I'm happy to answer any questions you may have.
Any comments or questions from the committee members? Dr. Hahn, thank you very much for a very comprehensive presentation. One thing you did sort of allude to is the ancillary benefit that these centers can actually become community health centers, not only for just students, but siblings and adult population also.
Mm-hmm. Yes.
Which is just an added benefit.
Yes, and faculty as well, students.
And of course, increased points of access to quality health care.
Mm-hmm. Yes.
Any questions or comments from the committee? Madam Chair, we're glad you joined us.
Thank you.
All righty. Chairman Cooper's joined us. All right. Any other comments, buddy?
Mr. Chairman, one question I would have is, how does this health center interact with the other health resources in the community?
They're often connected with other health services in the community, and the providers often come from other services in the community. There are also, I believe, efforts to link records so that what's done in the school-based health center is recognized at the other sources of healthcare for these students, so that there's that kind of exchange and non-duplication of services.
Thank you.
Mm-hmm. Okay, great. Dr. Hahn, thank you very much. We appreciate your presentation. Very, very informative, and it's a real benefit to the committee. Thank you. All righty, our next presenter is Ms. Diana Allen with Primary Health Care Centers of Dade County. Ms. Allen, thank you for being here today. Up from my part of the state.
Yes, we're neighbors. I'm not sure how to get to my slides.
Is this? It'll be this one in your packet. I think it might be the second one.
Thank you so much for this opportunity. I'm Diana Allen, CEO with Primary Health Care Centers. Corporate name is of Dade, but we have grown tremendously, so we call ourselves Primary Health Care Centers now. I want to tell you a little bit about our organization real quickly, and then I want to talk some too about our school-based program.
Certainly.
We are what's called a federally qualified health center. We have been operating as such for 37 years. What that means is in order to receive federal funding, we are a nonprofit independent corporation. We have a volunteer board of directors that oversees all of our operational and financial business. We have currently 8 sites that are approved by the Health Resources and Services Administration in Northwest Georgia. We are in Dade, Walker, Catoosa, Chattooga. All right, I'm going to forget something. We are in, let me back up. We are in Catoosa, Chattooga, Dade, Polk, and Walker counties in Northwest Georgia. We have 4 service sites, clinic sites in Trenton, Rossville, Summerville, and Cedartown. We have 2 school-based clinics. We just opened the second one. The first one we opened is in Tunnel Hill in Catoosa County, right on the county line, and the other one is in Lafayette. We have a mobile dental unit that we're getting ready to very soon, in the next few weeks, we hope, deploy. And we have one administrative site in Lafayette. The question about why school-based health centers, I think a lot of that has been covered already, but our mission is to provide the most accessible, affordable, and quality healthcare services across our service area, and that means that we need to be where the patients are. And especially in a school setting, it makes a huge difference, and I'll talk a little bit about that as I go on. But school-based clinics are particularly, having a clinic at that school site allows us to be where the people are every day, where the students are especially, but the faculty, the school personnel, the parents, the siblings, everyone can be served at that one location. And we do serve anyone and everyone from that community as well. You asked the question about that. It eliminates a lot of barriers that students and their families have in getting health care on a day-to-day basis, and it it affords a minimal interruption of the student's learning and day-to-day, as Dr. Johnson likes to talk about, seat time, the amount of time that the student actually spends in the classroom. We know from research that healthy children learn better, and we assume, I said we know, but I mean we assume that children succeed academically when healthcare and academics are integrated. And that's been our goal at both of our school-based sites, is to be as fully integrated as we can with the school and the school system. The services that we provide at our school-based sites are, of course, the primary medical care, acute care, chronic disease management, health and wellness focus. We provide general dentistry, oral health care, which includes your comprehensive dental exams, x-rays, cleaning, sealants, extractions, fillings, all of those services. We offer dietary nutrition services. We have nutritionists on our staff who do meal planning, counseling, and education. We also provide case management and behavioral health. And we have referral specialists and what we call patient navigators who help our patients and families with a lot of just navigating through resources and getting the either financial aid or other healthcare specialty services that they need. Our centers are open Monday through Friday with extended hours. We start before school opens and stay later after school closes to accommodate parents especially who work, and maybe high school students and others that need to come to the clinic after school or before school. We work by appointment, but we also accept walk-ins. We serve adults and children at both of our school-based clinics. We staff it with a full-time nurse practitioner and the medical support staff that they need. We have part-time pediatrician or a family practice physician who goes to those sites on a regular basis. We have a part-time dentist and the support staff they need, dental assistant, dental hygienist that work with them on the days that they're at those clinics. And again, nutrition, case management, behavioral health, and the referral specialist. We opened Tiger Creek Elementary school-based clinic in May of 2013, and we were fortunate enough to receive a capital improvement or capital grant from the Health Resources and Services Administration to purchase the modular building. So we are actually on the school campus, but we're not in the school building. They had limited space available, so we were very fortunate to get that funding. We have 2 fully equipped medical exam rooms in that modular building. We have a practically full-service lab. There's some lab tests that we do send out to a contracted lab company that we use, but a lot of the lab tests we can do on site. And we have, of course, I said our dental program. And I'd like to just tell you quickly about a dental patient that we have seen and continue to see. A 16-year-old young man from the high school in the county, one of the high schools. And he was referred to us by the school nurse with an abscessed tooth. And this young man had never been to see a dentist before. He'd never had any dental treatment. He's 16 years old. Horrible abscessed tooth, had been back and forth and in and out of the emergency room at the hospital for the pain, and nothing was being done to help alleviate him of the problem, to treat the problem rather than the symptoms. So he was seen by our dentist at Tiger Creek, and the abscessed tooth was extracted, and then he was put on a treatment plan, and he received cleanings. He's had some other teeth that needed filling, and I'm not sure, but they may have also provided sealants for his teeth, or he may have been too old by that time. But he is now on a routine follow-up schedule, so every 6 months he's seeing the hygienist, getting his teeth cleaned, and they're monitoring to make sure that his going forward, his teeth are doing well. As a result of him coming to the clinic, his whole family has come now. And so we are now we are the medical home, including the dental home, for his whole family. So those are the kind of children that we want to engage and get involved and become our patients, and so that we can also take care of the whole family. This is a picture of our nutritionist, one of our nutritionists. This is Charlie. Charlie is very special to us and always will be. Charlie was the first patient we saw on the first day that we opened our clinic at Tiger Creek. He came in with the school, actually the teacher, because the school nurse happened to not be there that day. The teacher brought him in, and he was in acute distress. He was having an asthma attack. And so we were scrambling. We were still, stalking the clinic. And but we found a nebulizer, treated him, got him stabilized, and found out, though, in doing his history, that he had not been getting his asthma medication on a regular basis. So we got involved with his family about helping them get his medicines. And going forward, we have followed him all along the way. He's become a patient on a regular basis. He comes to us routinely to get allergy shots. He has become a dental patient because he does, his teeth have come back now, so he does have some teeth now. So we've become his medical home, as well as his family. This is another situation where his siblings and his parents have decided that they will use our services as well. So these are a couple of examples of success stories where we feel like if we can get the child engaged or the student engaged, then we will be able to take care of the whole family, and that's our goal, as well as the whole community, as I mentioned. Tiger Creek Elementary School is in the Catoosa County school system, and we're talking about where to place these clinics, which schools. Catoosa County is kind of a unique situation. It's very close to Chattanooga, but there is a section of the county that has already been designated by the federal government as a medically underserved area. It's fairly isolated and remote from the rest of the county, where most all of the medical services are located, and it is it's in an area where there is a good deal of poverty. Tiger Creek is a Title I school, and currently they have about 68% of free and reduced lunches. And as I said, it's located in a medically underserved area. I've included some quotes from the superintendent and some other folks related to Tiger Creek and the other school, which I'll talk about in just a moment. But and I'm not going to read them all in detail, but the main thing I guess I want to point out is that without the support of the schools, the school superintendent, and the school board, this would have never happened. So that's an extremely important partner for this to work, and they've been wonderful to us in every way and extremely supportive, and always excited about us being there and what can they do to help us and how can we partner and work together to make it more of an integrated system. The interesting thing about Superintendent Reese in Catoosa County is, and one of her quotes at the bottom addresses that, she can really relate to the lack of services and the lack of care when it comes to dental health, oral health, because she said as a child her family struggled to provide dental care for she and her siblings, and she has, I guess, suffered the consequences of that as she's gotten older and become an adult, and she just recognizes how important that is for children. And dental care, it has been the main need that has come up to us every time we've gone into a community to talk about either a school-based clinic or another type of clinic, that is the biggest need and the biggest gap in services that is always identified. Walker County is where we have just opened our second school-based health clinic, and it's only been open about a month now. And so we're still very much in the throes of getting that up and going. But we chose that community. It's called West Lafayette. It's just west of the downtown part of Lafayette, but still kind of in a remote, isolated area. Couple of census tracts in that area are already designated as medically underserved as well. It's also a Title I school. Their free and reduced lunch percentage is 86, very high. So we always try to target the communities or the areas where there is the biggest need, where there's the most underprivileged, underserved, and medically needy. These are some quotes from the school principal at the school. It's called Gilbert Elementary in Lafayette. Once again, and the superintendent, we've just had tremendous support from everyone. This is a picture, sort of, of the Gilbert Medical Clinic. It's also a modular. That building in the background is not it. That is a storage building. It's the one in the foreground that you can only see a portion of it. But as you can see, we're still working. Right now, our staff are working in a room in the school. But they were pouring sidewalks, and this is our mobile dental that Gilbert will be their home, but we will be deploying it to other schools and communities that don't have access to very much dental care. Very soon we'll be deploying that. Just as an example of the community support that we've had, Gilbert was just recently certified as a STEM school, elementary school, and they're just doing phenomenal things with math, science, and technology. And a lot of what they do is environmentally. They have a garden. They have aquaponics. So the children got involved and are helping us plant some native type plants around our modular, and they're helping us with the landscaping. Roper is an industry in Lafayette that has gotten very involved with this also. So in terms of partnerships and collaborating in community, it really takes a lot of that to make a school-based program work. And these are some folks from Roper and from the school. Just real quickly, talking about the types of health problems that we see, and these are just the top, I guess, 3 or 4 that we quickly pulled together a graph. But at this point, most of the health problems that we're addressing are acute type problems. Okay. Strep throat, sinusitis. The hypertension, I think, has to be some of our adult patients, but it could be some of the children too. I'm curious to get more about that. But allergic type problems, so those right now are the top diagnoses that we're looking at. But we are beginning now, after 2.5 years at Tiger Creek, to see more children with more chronic disease issues, diabetes, a few weight issues. Obesity is not as big of a problem in our area as some other parts of Georgia. But we are also beginning to try to identify those children who have not had their well child checks and their routine annual visits and get those pulled in to see us. These are this graph shows the students broken down by site that we've seen so far, and the main thing I guess I want you to take away from this is how we've seen the growth that we've seen over the last 2.5 years. Of course, Gilbert, we've just got started, but we're pretty proud of the fact that we've already done dental screenings on, this number is a little low. I'm not sure when these numbers were generated, but I think as of this week, we've done dental screenings on about 165 of the students at that school. But you can see that we're seeing steady growth, which is good. We're happy with that. Now, this is the combined adults and children broken out by medical, dental, and once again, you can see the growth in those patients. Part of that is due to the fact that this past summer we did begin seeing everyone from the community, from the Tiger Creek community, and we will be seeing everyone from the Gilbert community as we go forward. So we're starting to see more folks from the general area of the school start to use the services. And these numbers are the combined medical and dental broken out by the 2 school sites. And these are encounters, number of visits that we've had. Just to talk briefly about the financial, we definitely have learned quickly that it's not like the Field of Dreams. We thought it would be, that, we build it and they'll come, but that hasn't exactly happened, and so it's taken a lot of outreach and education within the school system and within the community to let people know what we're about and what we can do for them. So we're at the 2.5-year mark now with Tiger Creek. So we're still trying to reach that break-even mark. We're very close, but you have to have the right mix of insured and uninsured, and Medicare and Medicaid and private insurance. And one problem we experienced was, and we do at every one of our sites when we open a new one, it takes 4 to 6 months to get your credentialing from Medicare and Medicaid. And we have to be open and seeing patients before we can submit the application. And as a result of that, there's several months initially of operations where we're not getting claims paid for the Medicare, Medicaid, and private insurance. So that's a struggle, and that has a negative impact on us from the get-go. So without other types of funding to help support the clinics and keep the operations going for those 6 months or more, it would not be successful. But we've been fortunate that we've been able to, with Gilbert, receive a new access point grant from HRSA, and we had some grant assistance through the Healthcare Georgia Foundation and the Emory with our Tiger Creek Clinic. And we have leveraged that money, that funding, to approach some other funders and foundations in our area, United Way and some others. So it's been an interesting, challenging journey, but a very positive one. We're thrilled and blessed. We think that we've been able to work with Dr. Johnson and her staff in Emory to accomplish what we have, and have learned a lot through the process.
All right. Well, thank you very much. We appreciate your presentation, and it's really important to show your numbers and your growth where and some of the types of services you're providing. You mentioned that you've got case managers and for referral specialists. Certainly you have to create that network within the region to have those referral sources available, and then navigators so that you can help to with enrollments as far as Peach Care, and then also probably under Affordable Care Act to help
Exactly.
As far as that.
Yes.
And then one other question that came to mind was, I've had a brain freeze here. Just like you say, have you had resistance from commercial payers as far as becoming certified in-network providers?
We have not.
Okay.
Mm-mm. No, we are covered now. It took several months process, but we are covered. When we're credentialed now with all of the private health insurance plans, commercial plans, and there may be one or two, but those are in Tennessee, and they don't like to come across the state line or something like that.
Okay. All right. Well, thank you very much for your presentation.
Thank you.
Any questions or comments? Chairman Cooper? 22.
Thank you very much, Ms. Allen. I do have some questions. First of all, we were talking about if you are part of the federally qualified health centers, is it just because you are a different site that you have to have your own credentialing from Medicare and Medicaid?
Yes,
even
ma'am.
Though you're part?
Yes, ma'am.
Are you a separate entity so that if
they're not? No, we're all of our sites are under one umbrella, which is the primary health care center. But yes, it's their requirement that each site be credentialed separately.
Okay. Then to the dental part, which I have some interest in. If you only have a part-time dentist, do you have a backlog of patients needing teeth cleaning and assessment?
We don't yet, but we're thinking we may be headed down that road. We've had the dentist at the Tiger Creek facility 1 day a week. We're just adding another day. But we also have a dental clinic at our Trenton facility. So, we can, if people can get to the other facility, we can refer them there. But we're gradually, as the demand increases, looking at how we can add more services, and we just added a second dentist. So we now have 2 full-time dentists working, and they're rotating their schedules so that we have every dental clinic covered, including the mobile unit, every day, Monday through Friday.
Okay, and obviously the dentists don't do the cleanings. That would be the dental hygienist. Do they operate under federal rules or state rules? Can they do dental cleanings when the dentists are not in the building?
They cannot.
Okay.
We would love to change that, but
that's what that was one of the questions I have. So the only day that they can do cleanings is when the dentist is there, even though the dentist has already seen the patient.
Yes, ma'am. And
assess them. Oh, okay.
That's correct.
Representative Taylor, you had a question?
Thank you. Just a quick. You're serving, we have several clinics in my district, so I'm very happy with the service you provide. Have you had any comeback from the private physicians, or these are mostly patients that are just not getting any care, or do you have some of both?
We have some of both, but more so children and adults who don't already have a primary care physician. Those that do, we have made arrangements to make sure that they understand that we're not trying to take the patient away from them, and that we will share whatever medical records and information that they need.
That's what I was looking for. I assume you have electronic medical records, and you can share that with their primary pediatrician if so needed.
We can. Now, we don't have the ability in our area for our medical record system to communicate with theirs, but we fax them information, we provide them whatever they need, and we try to always be sure to alert them that we have seen the child.
Good.
So,
one other question having to do with your PPO networks. I got it that most of the providers, the big carriers, you're with them now. How do you handle, or while you're in limbo getting certified, do you balance bill, or do you accept what's paid even if it's out of network? How is that working for your clinic?
Frequently we will accept what's paid out of network. And we always hope that once they do approve us, it will be retroactive to the day that we open, but it usually is not. So there's a gap of time and claims that we're not going to get paid for.
Okay. But again, now that you're in more networks, that's going to even out, I think, don't you?
We hope. Yes, ma'am.
Thank you.
Thank you.
Ms. Allen, thank you very much.
Thank you.
Any comments, questions from other committee members? All right, let's see, our next presenter is Mr. Clifton Bush with the Albany Area Primary Health Care.
All right, good afternoon.
Mr. Bush, thank you very much for being with us today.
Thank you for having me. Again, I'm Clifton Bush. I'm the Chief Operating Officer for Albany Area Primary Health Care. And so I will be presenting on our school-based health center program at Albany Area Primary Health Care. So just to give you a little history before we get into the school-based health center program, Albany Area Primary Health Care was a organization where the cooperation was initially established in 1978, and then our current institution was incorporated in 1979. How the organization started was there was a grant that was to develop a clinic in Lee County that was based on a thesis project regarding the lack of care for women and babies in the community, particularly prenatal care. Albany area, we did not implement OB services until about 30 years later, which was in 2009. As of today, Albany area, we have 13 clinical locations. We have 2 satellite clinics, one at Georgia Southwestern University, where we provide family planning services, and then we have an HIV satellite facility in Thomasville. And we have 1 independent laboratory and 1 administrative office. When we started in 1982, we actually had 3 locations. So we have had significant growth over the years within our organization since 2008, opening and are expanding 7 locations during this time, which includes OBGYN. We have dentistry now, where we have 5 dentists on staff, along with 3 dental hygienists. We also have podiatry, and we just started behavioral health, where we have licensed clinical social workers. We have a psychiatrist on staff and a nurse practitioner that specializes in psychiatry. So to facilitate our growth, our organization, we have a well-defined implementation model, which we always have an implementation committee that gets together whenever we are starting new projects or developing clinics. So our latest project that we have is the School-Based Health Center program, which we opened our doors to our first School-Based Health Center in March of 2013, which was at an elementary school, which is Turner Elementary. To give you a little bit information about Turner Elementary School, it has approximately 500 students in the school, approximately 50 faculty and staff members. It's grades K through 5. And in the school, 99% of the students are free and reduced lunch. So that should tell you, 99% or 100% of them have Medicaid or should have or qualify for Medicaid. Over 90% are African American. Less than 5% utilize English as a second language. So there are some patients that speak Spanish and things like that. So why a federally qualified health center as a sponsoring agent? Ms. Allen already told you about a federally qualified health center. We're the same type of organization as she is. But as a federally qualified health center, there's things that we can do when we start centers, school-based health center program to help sustain the program. There's a thing called the FQHC rate, or prospective payment system, where for Medicaid, when patients come in, we actually then a private practice office, our rate is higher for Medicaid than a private practice office. So when we get payments from Medicaid at our FQHC, our rates are higher, which helps us sustain the program better than one of the private pediatricians in the area. We're able to also qualify for different federal grants. We can apply for like NAPS, which is New Access Points. There are also other grants within the Health Resources and Services Administration that we can also qualify for. As a FQHC, we offer a sliding fee scale program, which is discounts for our patients when they come into the center on their medical or dental visits, if they qualify for it. We have various medications programs, such as the 340B drug program. We also have an indigent drug program where patients can get discounts on their medications to help them out. Also with FTCA, which is the Federal Tort Claims Act, our providers are covered under malpractice with this. So school-based health center sustainability. When we started our school-based health center, as Ms. Allen said, students, it's not that they're just going to come. So what we kind of did is we kind of thought outside the box, and we have to send consent forms home for the students in order for them to be seen. So what we did is we actually went through every consent form that we received from the students. And what we found out is probably over 60% of them would get their well child exam to get in kindergarten, and from then on they would never go back for their annual visits, which they should. So what we did is we utilized that, and what we did is went through all those and actually scheduled well child exams appointments for these students. So kind of when we started up, we started in March of 2013. We were already booked out for 3 months with these well child exams. Other things we've done is poster contests and prizes for the students. Without the support from the school system, support from the principal, support from the assistant principal and the teachers and the faculty and staff, there is no way that this can work, as Ms. Allen has already told you. So what we do is we do like poster contests to get the students involved. And we do things on, how to be a friend, or what is healthy to me, and teaching them about health. And what we do is, we take a look at the poster drawings and we select winners. And with the first drawings, we actually decorated the clinic so the kids can be a part of the clinic. Student involvement, school activity involvement, is very important. Going to the PTO meetings, so it takes time to go out and market this program, going to the faculty and staff meetings, marketing the program, talking to the parents about the program, and sending various things home to the parents. I already talked about relationship with the school administrators. Another thing we do is a wellness campaign for flu vaccines. We actually vaccinate, give the flu vaccine to anyone at Turner Elementary that wants it. So every September we send consent forms home to the parents along with the letter telling them about the flu vaccine. They send them back and we vaccinate any parent that sent back for their child to be vaccinated. We also do the same for the faculty and staff. We also vaccinate them with the flu vaccine if they would like it. And the other good thing is that hearing from the school nurse who goes to multiple schools and talking to her colleagues, Turner Elementary was the school that had the less flu cases last year than any other school in the county, and that was due to the flu campaign that we did. I already talked about well child exams. We also do an annual health fair event. So again, that's just involvement, getting the parents involved, the students involved, and the faculty and staff involved. And we have various screenings at that event, blood pressures, we do finger sticks, checking those things, and just anything that is abnormal, we always follow up on it and have them come to our clinic or one of our other facilities that may be close to where they live. Faculty and staff engagement, I already talked about that, but we also do, we see the faculty and staff, we also do adult health, we announce certain months as Adult Health Month. So what happens during these months is that we actually put flyers in the faculty and staff boxes, and what it says is, hey, you have the state health benefit plan, do you know you get a wellness exam for free once a year? And what they do is they sign up and tell us what day and time they would like to come and give us their phone number, and we actually make appointments for them. And majority of the faculty and staff at the school come to us to get their wellness exams annually. Continue with sustainability and just things we do to keep the center going. Medicare and the CMO enrollment for the, Medicaid and the CMO enrollment for Medicaid. We have licensed patient navigators as well. So when students come in and they are inactive, we do utilize those licensed navigators that we have on staff, working with the parent, because they can go on and initiate the enrollment for Medicaid through the Compass program. And so we utilize them when students come in with inactive Medicaid to help them initiate enrollment into Medicaid. Already talked about the sliding fee scale program. Collections, we don't turn away anyone that comes to our clinic if Medicaid is inactive or they don't have insurance. We still see them regardless if they have payments or not. We do attempt to collect payments, of course, because you have to keep the center going and keep it open. And that's the same for the faculty and staff. Billing assignments, we do have insurance clerks within our organizations who helps with billing. If there's any billing issues, they get with the administrative side and with the physician assistant to make sure that we're coding correctly and things like that, to make sure that our payments are coming in. As far as credentialing, we have a actual credentialing person who credentials our sites, also gets us enrolled into the different insurance carriers that we have to get enrolled to. And just piggyback on the last presentation, we did have an issue with Blue Cross Blue Shield when we started our school-based health center. They did not want to recognize us as a health center because it was inside a school. And so our credentialing person actually had the person from Blue Cross Blue Shield almost in tears on the phone after she told them the value of a school-based health center, and she actually got it approved for us to do Blue Cross Blue Shield, which at that time that was one of the carriers for the state health benefit plan. Other things, school-based health centers, the way healthcare is moving from more of a just seeing as an encounter, just seeing someone, it's moving towards quality of care. So there's different things that as a federally qualified health center, we kind of forced to follow certain quality improvement measures, and because we have to report them to the government. So there are different measures that we follow with the school-based health center that was kind of initiated through we also received a grant through the Healthcare Georgia Foundation when we first started our first center. And so these quality benchmarks, some of them that we follow are asthma, obesity, which we get the BMI, the blood pressure. We could look at the different labs we do for the patients, and also health maintenance, which is the number of well child exams, immunizations we give, etc. And so you can actually now you get it, of course, I'm sure you know, get incentive payments if you're performing well with your quality benchmarks from the Medicaid and the CMO organizations. So we try to make sure that, and we actually track these things. We have a spreadsheet where we track these things monthly to make sure that we're meeting and doing the best quality care that we know we can do. If you look up here, our encounters, as far as attendance, if you look at these encounters here, you see that in October, which is kind of our flu time, we give all those flu vaccines, we had the highest where the students, we saw total number of patients and individual users was 284, total number of encounters was 392. So just think, if these students if the parents had to come pick them up and take them outside the school, how many of the parents would probably bring them back to school after they have already taken them out? They're not. So these kids come down to the clinic for 15 to 30 minutes at the most, and they go back to class. So that tells you how much seat time school-based health centers are keeping the kids in the classroom. And also on here, you'll see the number of adult users. That's mostly the faculty and staff. We do see parents sometimes. Currently, our clinic we do the student siblings, which is brothers and sisters, and the faculty and staff. And we do see students from surrounding schools. But we do, as you can see, adult users are mostly the faculty and staff getting those wellness exams and things like that. This just shows you our asthma quality data, the number of patients with asthma. It also shows you the number of ER visits that have happened because of a child's asthma. And as you can see, we had some ER visits at first when the clinic, but as we have kept going on, I think the quality of care that we're providing at this facility, you see that there are no ER visits from the students that are being seen at Turner. So again, that tells you the value of the program. And this just goes to show you the percentage of patients on asthma pharmacological the medication, and it just goes to show you that this is something else that we track, and showing you that most of the patients that are in our program are on the correct medications and some type of medication for asthma. The next slide, it shows you the well child exams. Again, this shows you the number of students enrolled in the health center and the number of well child exams that we did from 2014 to 2015. It gives you, they're broken down by 3 months at a time: first quarter, second quarter, third quarter. So if you look in the first quarter, a lot of times, and the principal of the school is going to speak in a second, but school starts in August, of course. As you can see, that's the highest time, because a lot of times the parents don't take them to get, they have to have certain things to get enrolled in school, and there's a number of students that cannot get in school because the parents haven't done what they are supposed to do. So when they come to Turner, the principal and her team up front sends them right down to the clinic so they can be seen and they can go in and get enrolled in school and not have to go outside the school. So you can see the highest number of well child exams are done when school first starts, because those kids haven't been to get what they need to get in school. All right, just to give you a little bit more information, we are expanding our school-based self-center program. We have some new sites that are opening. We have another elementary school that we're opening in Albany, Georgia. We just got approved last week, Dooley County School System, which is in Vienna, Georgia. We will be opening a school-based self-center there, which will be medical at the elementary and middle school. And we're also opening a dental site at one of the middle schools in Albany. And we do break even with our school-based self-center program. So we do pretty good. And I think the things we do, thinking outside the box and going ahead and utilizing those consent forms we get and calling and making those appointments for, children that have not been seen in 3 years or 2 years from a doctor, etc. But initially, the Healthcare Georgia Foundation, that grant that we received from them was a huge benefit to our organization. And I think utilizing that grant and the things that we did, and as far as pre-planning for that grant, helped us to get where we are today. So funding is very vital for starting programs like this. We also do dental services, as well as we do have behavioral health currently. We have a licensed clinical social worker that comes to the school. And something happened to one of there's some slides missing, but I'm just going to talk about them. They're not in here for some reason, but they might probably on your sheet. But to start a school-based self-center, you probably hear most people say it takes around probably $250,000, and that's to have a comprehensive school-based program. The one that we started, we have a mid-level, which is a physician assistant in our school-based health center. We have 2 medical assistants. We started out with 1, and the numbers just grew, so we had to add another medical assistant. We also have the licensed clinical social worker, which we added a year later. The school system in our area actually was so generous. They knew the benefit of a school-based health center, and they actually did the renovations for us. They have a maintenance department, so that was kind of in kind. But other school system, other centers are not that fortunate, so they would have to do those renovations themselves. The salary of a physician assistant for ours is about $80,000 starting out. So then you have the medical assistant, which is about $25,000. And then you have the in-kind. You have to have oversight from a pediatrician who oversees our physician assistant, and then we also have an internist for the adult patients, because someone has to, make sure and supervise them and sign off on any charts and things like that. So overall, to start our center, it was around probably $180,000. But again, we didn't have behavioral health in there at first and things like that. We added those things kind of after the center was sustainable, etc. Right. And I think that's all I have. Any questions for me? And that shows you pictures of our open house from the first center that we had.
Mr. Bush, thank you very much for your presentation and displaying a very successful program that you have in the Albany area, and I'm sure those students are benefiting from it every day. Any questions from committee members? 18.
Yeah, thank you, Mr. Chairman. I was just wondering, I know you do have the 340B drugs, and we all know that medications are going up at a rapid rate in as far as manufacturers' prices and the pharmacy benefit managers' copays. Are you still able to get reasonably good pricing on most of your 340B drugs, or is that also escalating very rapidly?
Currently, the prices are okay with our 340B program. We haven't had any patients to complain, and I meet with the pharmacies that we contract, because we do contracted pharmacies. Yeah. I meet with them regularly, and the prices are okay.
All right, so those are bought on government contract, I guess.
Correct.
Is that correct? Okay.
Right.
All right. Okay. Yeah, well, that's good, because that is a major expense in this day and time.
Right.
Thank you,
Chairman Cooper.
I have a couple of questions. You say you have physician oversight. Does the physician ever see the patients, the pediatrician and the internal medicine?
No. So what happens is it's just so the pediatrician that we use is within our organization. So it's one of our pediatricians and then one of our internists as well. And so no, they don't ever come in. The physician assistant actually sees all the patients, but it's just so our PA cannot write for controlled substances. So what happens is the pediatrician does come over and she has to sign off on those things. So that's the oversight that she does, and she also comes over to make sure, are there any issues with the clinic? Do you need help with this? Also, sometimes physician's assistant has to call her just to get, I need advice on this. And so those are the individuals that provide oversight and supervision for her if things are needed.
Okay, what if a patient needs, physician's assistants are not medical doctors, and they have limited abilities. What if you get an adult patient or a child that is beyond their capability to handle? Do you send them over to one of your clinics, or what happens to them?
We send them over to one of our clinics, or, we haven't had to do this, but a pediatrician can come over. We have a main pediatric clinic. Our pediatric clinic is like a block away from the school. Okay. So they can actually come over there, or we will refer them to one of our pediatricians.
Okay.
Or one of our internal internists.
Do you keep any kind of records about how many referrals that the nurse practitioner or PA makes?
To pediatricians or there's been a couple. Not many though. Probably a handful. There was one child that came in, just to give you a success story as well, and this ties into when she had to call the pediatrician. A child that came in, and they were actually not we were not their primary care provider. They were seeing another pediatrician in the area. So the child came in, and it had fell in the lunchroom. And so when they came to us, they was just coming to us for the fall. But when talking, the child's heart was just racing, and then when the physician assistant got on the phone with the parent, she said, "Oh, her heart has been doing that. It's been doing that." Took her to the doctor, but to her the child's pediatrician, and they didn't really find anything. Come to find out, she consulted with our pediatrician. The child had to be flown to Macon. If she wouldn't have got to us at that time, that child had to be admitted to ICU in Macon, Georgia, and the child could have died. So that just tells you, our physician assistant did a thorough and good job, and the child had another pediatrician. So, okay. But just to give you one of the success stories from and how she collaborated with our pediatrician.
All right, and the other question I have is about the asthma data, and it says it's the percentage of patients on asthma medication. Is this the patients who come? It makes it sound like everybody has asthma. But
no.
Just the patients.
Just the asthma patients, yes.
But they all end up pretty much 100% on medication for treatment. Okay.
Yeah.
All right, Representative Taylor, you have a question?
Thank you, Mr. Chairman. Just a couple of questions. And I have visited the clinic, and It's a wonderful facility. I'm very proud of what you have. Just a couple quick questions. Do you have an average number of patients that are seen in a day? It looks like you stay pretty busy, so it's well needed.
So yes, she can go from 15 to 20 patients a day.
Okay.
The least she'll probably do is 12. But what has happened at that site is the site used to have a school nurse, and the school nurse in the school system, they laid a lot of them off. So there's only a school nurse there like 2 half days out of the week. So all those students come to us. So she can do anywhere
Right.
15 to 20 a day.
And I wanted to ask a question about the prescription. Do you actually dispense them there, or do you send them to a pharmacy to get it filled?
We normally do e-prescribing, which is electronic. That's another thing. You've probably heard of meaningful use requirements from the government. They want us to e-prescribe.
Right.
So she normally e-prescribes everything. If there is a prescription, like the controlled substance, that has to be, those have to be picked up. The parent has to come to the school to pick them up. We don't give them to the students.
Okay,
To
thank
take.
you.
All right, Representative Gardner, you had a question or comment?
Thank you. I was interested in, and you maybe put this in your report somewhere, but have you kept data on the reduction in the visits to the emergency room?
Yes. So we do for the asthma patients. We do follow the reduction in ER visits. That is something that we're working with our ER department on, as far as a whole, on the reduction of ER visits. And that's not just from this center, but all of our centers. We're meeting with the executive staff of the hospital to get that data from the ER department.
So to expand beyond asthma, in other words.
Correct.
Uh-huh.
Correct.
Thank you. That'll be important.
Okay, any other questions or comments? Thank you very much. Thank you, Mr. Bush. We're going to vary from the agenda just a little bit. We're going to ask Dr. Deborah Jones, who's the principal at Turner Creek Elementary in Albany, to make her presentation about her experience with school-based health centers.
Good morning, and thank you. I have a PowerPoint, but sorry. Thank you. I do have a PowerPoint, and for the sake of not being redundant, you want me to, you can go ahead and pull it up. I just go to the slides. But while she's coming, Mr. Bush really covered Turner's health-based clinic. So I'm going to speak to you just from a principal's perspective, the benefits that we look for and how it helps us. And so I won't go through some of the data because I kind of repeated some of the things that he had. One main thing. Okay. One main thing we have, and I can talk through this, we are looking at a community approach as we go into our school. That means everything that we do, we are oriented to the parents, the community, in a healthy sense. So we've changed our school culture. We know that healthier kids learn better. One key thing that principals we look for is academic achievement. It's the bottom line, increase in academic achievement. In order to get this, one of the factors that have always been an issue is having that instruction seat time and having students there. So when students go home for a doctor's appointment that lasts maybe 30 minutes, they don't return. And that was one of our big issues at the school, as far as missing a whole day for an hour's appointment. So that is a tremendous increase, and we will see that data when we conclude this year to do a 2-year comparison. It is tremendous. Immunization is major. We know the flu season takes students out for several days. That have been tremendous. The dental care. We have several students that do not visit the dentist being there that one day. We have observed on Wednesday currently. It has been great. Again, from a school perspective, we look for transitions that do not interrupt the day. We don't have to stop and find kids. We have a very good collaboration that we work with through the dental as far as the primary care health, where we work to collaborate to make things easier for the students returning and as well as parents. Many of our parents do not have transportation, so they're walking to get their children to and from school. We're able to see students with consent from them without them actually being there. And that is also tremendous. We're able to get them served. School-wide changes that have been great. Because we are the first school in Dougherty County that have housed the primary care facility, and now we have the dental care, we have decided to turn our whole school theme around to healthy care. So we do things throughout the school and community. And some projects that we've worked on, which is great for our staff, I think we all suffer sometime or another with weight. So we've decided we do contests, Biggest Loser contests, that it's, I call it Sarah, my nurse Sarah, checks our body mass. She's in it with us. Demonstration, we do cooking demonstrations. We just started. We had our first one. So we are also, and that's open to the parents and community, where they actually have people coming in. We have 6 scheduled for this year, and they'll come in and teach us how to cook and eat healthy, the staff and the parents, because we want to make this a whole team approach. And we also introduce snacks, healthy snacks to our fundraising. We will be actually selling bags of strawberry and grape and mixtures to our students. They love it. It's fruit that they don't normally get. Introducing new fruit to them that they don't normally see, starfish and all that, little star fruit, not starfish, star fruit, to them as well. So this gives them an opportunity to eat healthy, and they think it's just like candy to them. They enjoy it. So we're trying to change that tone of buying candy after school, and we actually starting to sell little fruit and things. So that helps us tremendously again. The health fair has been a tremendous success, where we bring in the parents, community again to come in, get health checks. Many parents that have come in have shared that they had issues that they didn't realize they had because they don't go to the doctor regularly. But being there and going through, getting blood pressure checks and everything, that really helped. So that's some of our biggest points. And I won't go through, the slides because it did cover a lot of stuff that Mr. Bush did. But partnerships that we have with the community, the schools, the relationship that we have, it's seamless in terms of transition in time and very beneficial to it. As a school principal, I keep my students there. I don't let them leave unless it's major. If Sarah tell me they need to go home, they go home, but if she don't, they stay there. We take care of them, we teach them, and we dismiss them at 2:30 every day.
Great.
Wonderful.
Okay.
Are there
All
any
right.
questions?
Any comments or questions? One questions I've got with the clinic on site. Can you see a measurable difference in absenteeism?
Yes, we will do at the end of this year, we'll have a full year comparison because we started late spring. Okay. We are trying to monitor that now, but we don't have all the students pulled out, so we have clean data without being screwed by the end of the year. But going home is, we know that because I deal directly with that.
That's the second choice rather than the first choice.
Yes, yes, they stay.
Okay. All right, any other questions or comments from committee members? Thank you very much. I know it's a long drive up here and being away from your school. You sounds like you're very pleased and got a very successful program going.
Yes, sir. Thank you for the opportunity to speak.
Well, thank you, Dr. Jones. Thank you for being with us. All right, we'll jump back up. We've got Mr. Atiba, and I'll butcher this. Mr. Atiba.
You won't be the first one.
Maybe. Okay, thank you.
Thank you.
All right, if you'll help me, it's Mibawan.
So, you know the
Mibawan?
sound you make when something tastes good?
Mmm-B-Wan. Okay.
Like Obi-Wan? Mmm-B-Wan.
Okay, all right. Thank you. Thank you for being here with us. You're with the Zeiss Foundation.
Yes, I am.
All
yes,
right.
I am.
Thank you.
You going to set me up? I'd like to take a moment of personal privilege before we start and just say that last night I was on cloud 9 because I had my 5-month-old grandson with me. I got to do the daddy rock and put him to sleep.
That's special time.
Oh, yeah. No, it is. And I have to say that sitting here listening to all the presentations as a representative of the Zeiss Foundation, I felt like a proud grandfather because we never get to hear this directly from the folks who operate these centers. We always get great reports from Dr. Vita Johnson, but to actually hear people coming from the front lines speaking about the power and the impact of the school-based health centers just really makes me feel proud. And I just wish others from the foundation were here with me to share in this. So as I said, I am here with the Zeiss Foundation, which is a family foundation based in Atlanta. We are unique among foundations in Georgia because we fund nonprofits across the whole state of Georgia. But we also have this thing we call place-based philanthropy, where we adopted a neighborhood back in 1994 and have stuck with that neighborhood over the past 2 decades, now going into our 3rd decade. There are other place-based funders. I think you all know Tom Cousins, his cousin family foundation in Eastlake, the work they've done in that neighborhood. The Annie E. Casey Foundation, which produces a kid count book, they've adopted the 5 neighborhoods that surround Turner Field. So we actually do convene and collaborate together on this place-based work we do. But like I said, we also do work across the state. And so our place-based work helps to inform our statewide work and vice versa. Our focus is on nonprofits that serve children and youth from birth to 18 years of age. And we have 3 categories that we fund in: the education, arts and culture, health and human services. And this falls into the health and human services bucket, which is actually our largest in terms of grant making. Education has the largest number of organizations, but health and human services is actually the largest in terms of the number of dollars that we pay out. And last year, in 2014, we had a grant-making budget of $10 million. And I would say that of the $10 million, about 85% of it covers out statewide, and about 15% in the neighborhood, the place-based work. This photo actually is a photo from many years ago of the Brumley family. So the foundation is called Zeiss, and it's a little bit easier to pronounce than Biwan, but it actually comes from a town in the Netherlands where Dr. Brumley took his family on sabbatical and they spent a year. And it was such a powerful experience for the family that they decided they would name their foundation and their company Zeiss. And so a little over 25 years ago, in 1989, they established the foundation to engage their 5 children and their spouses in the work. And so from 1989 to 2003, that happened. And then 2003, the family had a tragic accident where 3 generations perished in a plane crash. And so the 2 youngest daughters, Nancy and Marie, who did not go on the trip, have really maintained a legacy for this family by continuing the great work of their parents and their siblings. And so now Nancy, Marie, and Marie's husband Brad are the 3 board members who we meet with every other week. And I can tell you, I work for the Arthur Blank Family Foundation. You don't have that level of engagement by board members. So we meet with them every other week to review the kind of work that we do. We have 4 staff members. 1 staff member actually lives in the neighborhood. And Dr. Brumley hired him when he saw him lead neighborhood meetings back around 2000. And Gary Long was working for SunTrust Bank, and he liked the way Gary managed those neighborhood meetings. And the thing that Dr. Brumley saw, because he was not just a pediatrician, but a researcher, and he realized that the neighborhood was going to change significantly, because in 1994 it was an underserved neighborhood, not many amenities. And right around 2000, a developer determined that he was going to buy an Atlanta gas light industrial site and develop the Edgewood Retail District. And so in town, in that neighborhood, you have everything from Lowe's to Kroger, Barnes & Noble, and lots of restaurants, and that neighborhood went from being underserved to being overserved. And as a result, we now are into affordable housing. And so, again, the work in that neighborhood has evolved over time, but it all began back in 1994 with the opening of the school-based clinic at Whiteford Elementary, which again is in the city of Atlanta, but in DeKalb County, right off of Moreland Avenue. And as you can see, 1994, a much younger Dr. Vita Johnson there, cutting the ribbon for the first pediatric clinic at Whiteford Elementary. And Dr. Brumley is in the background there with several leaders from Atlanta Public Schools. And Dr. Johnson, who was a student of Dr. Brumley's, took this assignment to heart and led it from 1994 to 1999 to open the second clinic at Cohen Middle School. And then 10 years later, in 2009, Dr. Johnson was ready to take this clinic model around the state of Georgia. And what I wanted to share with you, again, these are just some of the organizations that we support in that neighborhood to do the neighborhood work. But Whiteford, down there near the bottom, is really the umbrella organization for a lot of the work that happens with the school-based clinic, the early learning program, and affordable housing. As you can see, we've done a lot in that neighborhood, even a community garden to add to the health work that we've done. So what we've done with that model is really what I would call holistic development. And it's based on this book that Dr. Brumley was carrying when I first met him, called From Neurons to Neighborhoods. And it's really addressing the holistic needs of children and families, making sure that all those critical needs are taken care of. And so, again, as you know from the testimony so far, we're all over the state. In 2009, when the economy was getting ready to go south, our board made an investment in this vision and said Dr. Johnson and her team would have $3 million over the next 5 years to do startup across the state with several planning grants. And again, that's an earlier slide, so it's more colorful than that now. And last year, as they were wrapping up that 5-year grant, they came to us to say they're really trying to concretize, the lessons from it. And so we gave them a capacity building grant to work with a consultant to really figure out how to structure this going forward. And so that work is sort of winding down. And believe it or not, in 2 weeks we have a board meeting, and they're on the docket for another year of support that I'm quite sure our board will approve. But I would say some of the lessons that we've learned from this work that has informed other work that we've done is really that the amount of money that we have as a foundation, the nonprofits look at it and probably say, wow, you have a lot of money, but we know it's a drop in the bucket when you think about the issues with education, health, and so it's really about public and private partnerships to figure out how best we can work together to do that. And from the federal level all the way down to the school. And we think it's important for people to have skin in the game. And so we want to work with you going forward as this partnership develops. The other thing is that, we have a way of dividing life to make it more difficult. And we know that if we do segregate things and operate in silos, we're not as effective. And so, again, I think one of the things Dr. Johnson's been great about is connecting the health in a broader way to the education. And some of the testimony, again, shows you how powerful it is. And third, that the results come continuously, early on, later on, and sometimes you don't even know it until too many years later. And Dr. Johnson could certainly testify, to some of those. The thing that I wanted to point out that to me is not always evident to folks who are in different professions, but a lot of the families that are being served, they actually get paid by the hour. And so every hour they miss taking their sick child to a doctor, getting on the bus, and so forth, is money that they can't make. And that their ability to, again, be served at the school level not only helps them in terms of family income, but in terms of the employer. It's a win for the employer because, it's another employee who shows up to work on time. And so in many ways, it's a win-win-win. And again, I think some of the outcomes we've seen are really impressive. And like I said, I'm sure our board next week will likely approve another grant to them. But I'm willing to take questions from the committee.
All right, thank you, Mr. MB1.
You got it.
For being here, and thank you for the generosity of the foundation and your leadership there. And I think an added benefit, I think these early interventions can show a lifetime return on investment for those we serve, and that's what we're all about. Let's get the best outcome possible, and so that we've got, like I say, a lifetime return on investment. Thank you very much. Any questions from? Okay.
I don't have a question, but I hope you will go back to the Brumley family and express our appreciation for the foundation and the work that they do. Government does not have all the answers. In fact, sometimes we're very ineffective. And certainly we work better at private and public partnerships, if not letting the private sector do it better than we can do it at times. And so I hope you will convey to them our thanks for all that they're doing for the kids across Georgia.
I will.
Thank you.
I'll be honored to do that.
And, I think what you do is you plant that seed that will grow and prosper and sustain itself over and over and over again. But thank you very much for being here. Any other questions from the committee or comments? None? Okay, thank you for being here. All right, then let's see. Our next one is Ms. Lynn Meadows, Coordinator of Student Health Services for Fulton County. Ms. Meadows, thank you.
Just hit escape and click on your name.
Hit escape.
Thank you very much for being here today.
Did I get it?
That's you. Yes, ma'am.
Did it. And I'm not technically savvy, so that was good. Good afternoon. I'm proud to come and talk to you a little bit about our school-based health center in Fulton County School System. I'm Lynn Meadows. I'm Coordinator of Student Health Services for Fulton County Schools. So a lot has been said this afternoon about school-based health centers, so I'm going to try not to be redundant, but I do want to tell you a little bit about what's special for our school-based health center and why it's so important in our community and schools. This is an actual picture from one of our classrooms. So let me tell you a little bit about Lake Forest and why Lake Forest. Lake Forest Elementary School is fairly new. It was built in 2008. It sits in the middle of Sandy Springs, and when you think of Sandy Springs in Metro Atlanta, you may get a picture of what's very different at Lake Forest. You get a picture of very, very nice homes, very, very nice schools, etc. And Lake Forest is indeed a very, very nice school. But our population is 95% Hispanic. And 85% of our children have difficulty speaking English. So if 85% of our kids have difficulty speaking English, you can imagine the percentage of their parents. Most of them serve as interpreters for their parents, believe it or not. So back in 2008, when we opened the school, we started finding some things out related to health. 70% of the kids at that time were not properly immunized, unfortunately. 80% of our parents, actually through a survey, expressed to us that they did not trust or were not seeing a physician or didn't have a medical home in the community. 41% of those children didn't have any type of health insurance. So there were lots of health needs in the community, and some of the barriers also included, if you think about where Sandy Springs is located, but if you think of where Lake Forest is, and Lake Forest is, if you know where Roswell Road is, right behind some of the shopping areas, right before you see a bunch of apartments, that's where Lake Forest actually sits. So a lot of our parents didn't have access to transportation. There were financial issues. There were issues with immigration and fear of being, if they went to a provider, having to disclose information about their family. So there were just lots of issues. So what we did was, after the school was opened in 2008, like I said, through things like our immunization audits, et cetera, and we found out that there were some significant needs of our students, we really looked at the community, and the community looked at us to say, what can we do for our children? We know that clearly, you heard today, there's a clear link between academic success and health. We wanted these children to be healthy so that they could be academically successful. So through a lot of planning, and thanks to Dr. Vita Johnson and the Emory Urban Health, we actually applied for and were awarded a planning grant. So our planning took years. So from 2008, when our school opened, to 2013, when our school-based health center officially opened, all of that time we were in the background planning for our school-based health center. But we didn't do it alone. It was through these wonderful organizations like the ZES Foundation, through the Healthcare Georgia Foundation, Kaiser, we were able to open our school-based health center. So fast forwarding to today, as I said, we opened our school-based health center officially in the fall of 2013. Lake Forest has about 900, almost 1,000 children, and I'm proud to say that of those 900 and something children, 700 of them have consents to be seen in our school-based health center, which is great. We provide the primary health care services to patients and students via a referral system, and I'll talk to you a little bit briefly about our referral system. But we also now are able to see what we call our alumni students, and those are our students that have left our elementary school and gone on to our middle school. We also are able to see their siblings and the staff. So some of the services, of course, we provide are for acute illnesses, chronic conditions, immunizations, physicals, and checkups. We also provide at our school-based health center behavior and mental health services, health education, and nutritional counseling. We also have some other programs and services that I'll talk real briefly about. This is just a picture of some of our board members and community stakeholders when we had our open house in November of 2013. And again, you see a younger version of myself and Dr. Johnson. And you see pictures of our school-based health center staff. To talk a little bit, again, I mentioned briefly about our initial funding of how in the planning phases, how we got started. But in terms of how we actually were able to open our school-based health centers, it was really through the assistance, again, of Emory, the Healthcare Georgia Foundation, and Kaiser. You can see on this slide, we received a $160,000 grant from Healthcare of Georgia, $80,000 grant from Kaiser, and that initially that funding went to providing our providers. So our nurse practitioner, our medical assistant, our licensed clinical social worker, and then our health educator. So providing services for our students. In all of Fulton County schools, we have a school-based clinic. The clinic is manned by an unlicensed healthcare worker that we trained. And then I have a staff of registered nurses that kind of work as case managers like in a hospital. So they oversee a geographical area of schools and make sure that all of our school clinics are working properly. We have protocols, policies, and procedures in place, the whole 9 yards. So when we looked at adding the school-based health center, one of the things that we did not want to do was change the concept of what we already provide for all of our students in Fulton County. So the nice thing about school-based health centers is you don't have to change anything that you're already doing. It's an added benefit. It's so wonderful. Instead of us referring children out to a community provider, we simply just walk them down the hall, which is wonderful. So nobody has to have an umbrella, nobody has to have a coat, parents don't have to worry about transportation. Like a day like this, you can just simply walk down the hall. So if you look at that slide real quickly, you'll see the Lake Forest Elementary School Clinic, where our teachers and staff, just like now, if a child needs to come to a clinic, they go to our regular clinic on site. Our team, our Fulton County staff, will see the child. If we determine that child needs to be referred to the school-based health center, we first make sure that they have a consent. If we verify that they have a consent on file, then they are walked down to the school-based health center and they're seen there. So the Family Health Centers of Georgia is our provider. They're a federally qualified health center. They operate as its own entity. Again, you have to have parental consent. It serves all of our students that are currently there with consent, but also our alumni, siblings, and staff. This is just a quick picture, and we're so proud that I can show you some data actually from Fulton County and Lake Forest. So you can see, and these are just some health-related data from previous years before we had our school-based health center. We have a very active clinic there. Lots of kids get sick. You can see pretty much in 2011, 2012, there were almost 6,000 clinic visits. These were our regular clinic visits. In the next year, there were over 3,000 visits. But really, for an educator and for the school system, what was so alarming is when you look at the number of students that were sent home. So 753 kids were sent home in 2011, 2012, 400 and something were sent 2012 to 2013. And as the principal said, one of the things that, again, any educator will tell you, any superintendent will tell you is seat time and attendance is vital. It's so important. So we knew that the goal of our school-based health center was to improve seat time and to improve attendance rates. So the next slide, I'm going to actually show you how we did that. So this is actually full data from our last school year, and as you can see, we actually increased seat time. So when we went into this, I should have said this when I was talking about giving you the background. When we went through the planning, I will tell you quite honestly, our board was very concerned about implementing a school-based health center in Fulton County for various reasons. But we made sure that all of the reasons why they cited as concerns, we addressed those issues. And one of the things that we committed to them was that we were sure, my reputation was on the line, that we were sure, though, that the data was going to show we were going to improve seat time and attendance. And so a year later, our board was so impressed. Now they're gung-ho about school-based health centers. So as you can see from this data, and this is last year's data, so this is recent data, 436 kids were referred to the school-based health center from our school clinic. 58% of them were able to return to class that same day. 42% of them were actually sent home. So I think on your in your handout, there may be a typo. The slide is correct. Your handout may be incorrect of the information I'm going to share now. The missed days of school, so of the 184 kids that were sent home, 62% of them didn't miss a day outside of that day that they were seen that day. Got it? So that was 0 days missed school.
They've got the right one.
Okay, you got the one. Okay. So, and then 27% only missed 1 day. 2 days or more, only 11% of our kids missed days. And I will tell you, this is important to us because before we implemented our school-based health center, again, when I talked about kind of the population that we serve at Lake Forest, many times the kids would go home with an illness. They would never be seen by a provider. So the parent would just keep them home until they were well enough to come back to school. So many times they would stay home anywhere from 3 to 5 days. A whole week would be lost in instructional time. So as you can see, we're very proud of how our numbers look and the statistics. Here's another slide that addresses our attendance rates. As you can see, the number of clinic visits for the yellow represents school year 2013. The green represents school year 2014, which was last year. And if we just look at last year alone, we had, again, over 4,000 clinic visits, over 3,000 clinic visits in our school. 3,018 of those kids, of the 3,358, were able to return to school, return to class. Those that were sent home was only 240 last year, from when you saw the previous slide when we were sending 700 and something kids home and 400 and something kids home. So very impressed with that. So some of the other programs and services and special projects that we offer at our school-based health centers, some other school-based health centers talked about flu vaccine clinics. That's extremely important. Last year we vaccinated over 300 kids at Lake Forest. The wonderful thing about that is we vaccinated 100% of the kids that had asthma. That's huge. We also have several wellness programs, Cool Kids wellness programs. Our kids love the Wellness for Youth fitness program, and the family. We actually also have a family fitness program. We have something what we call that we call the Lake Forest Obesity Lab, where we're focusing on specifically childhood obesity and looking at their BMIs and providing services and nutritional classes, etc., for the family. We offer student counseling sessions, parent-family counseling session, an asthma management focused care, and then we do lots of staff wellness activities. Here are just some pictures from some of our activities that we had, some of the Cool Kids Youth Wellness programs, and a race that we had, and some of the family fitness programs. This is actually a picture of our school-based health center. So when you walk into our school, you can actually see the doors of the school-based health center from our door. That was very important to our board because our board wanted to make sure that we addressed any safety issues with just people walking in the building for security reasons. So our school-based health center is actually located physically in the school, right near the front entrance. Where you see those arrows are the two doors. The first door is where we actually have parents and students that come and wait, and the second door is actually where the provider sees patients. We also have some other offices for our health educator and our clinical social worker. The next slide just shows the team of folks that I work with every single day to make sure that our school-based health center is successful. We have what we call a collaborative team meeting. We meet twice a month. And I hope that tells you how important this is to us. We don't wait till a problem comes. We try to make sure that we address any issues by meeting with the principal, the folks from the school-based health center team, myself, my nurse, and Paulette Abbey is actually my registered nurse that serves the schools in that area, and she has been the catalyst for our school-based health center. Wonderful, because she came from Michigan with school-based health center experience. So she has been an awesome blessing to us to have. So the collaborative team meets bi-monthly, and then we have an advisory committee that meets quarterly. And as you can see, those are other folks that come from outside of our school district, so that we can make sure that, again, the services that we provide at our school-based health center are top-notch in quality. So in summary, I will just say what everybody else has said, that we have seen and shown such positive impact from having a school-based health center. Some of the benefits and accomplishments, again, include having immediate access to primary health services for our families, affordable health care, which is, again, for this population, extremely important, and for every population it's extremely important. And again, we were able to decrease the number of students sent home from school, improve seat time and absences, and now we're participating in some national initiative because of our data and our work in Fulton County at our school-based health center. Thank you so much again for allowing me to share.
Thank you. Thank you. A very positive report, and your data is very impressive.
Thank you.
Your outcomes data is very impressive. Any questions from committee members?
I got one.
No.
Not me. I got a question.
Okay, go ahead.
Ms. Meadows, thank you very much. I think I'm probably reading something wrong, and that's why I'm going to ask this question. Okay, you had 436 referrals to this year is what you're reporting to the school-based health center, 436, something like that.
Yes, ma'am.
Okay. How many people, if there's 180 school days, or about 180 school days, that's something right around 2.5 visits a day. That doesn't seem that would be a tremendous utilization of, is it a nurse practitioner there and an aide, your staffing? It seems like they would have a lot of time on their hands.
No, so these were just the referrals from the clinic. So these were actually kids that got sick during the day. The school-based health center also makes appointments, so they have other children that they see on a regular basis. So like our kids from the middle school, they have appointments that they come in. So on an average, for our school-based health center, our nurse practitioner sees anywhere from 4 to 5 kids that may come on a daily basis just from the school-based health center, from our school clinic, but then they also see about 5 or 6 other children that may come from other routes, either through clinic appointments, scheduled clinic appointments, or from the middle school, or siblings, or staff.
Okay, so, because it looked like.
So it's just one source of, and we just pointed this out because for our board, it was real important to show them, again, that collaboration between our school clinic and the school-based health center.
Okay, well, it still seems to me that's a little bit underutilized, that it could be perhaps, for what it costs to run it, utilized better, that somehow or other it could be promoted where there's certainly a bigger need out in the community, and I don't know how you go about doing that, but it just seems like that they could be seeing more than 10 patients a day or something.
And again, so this was just data, I will say, from an excellent question, because we actually need to make sure we put this qualifier on here. This was just children that are seen by the nurse practitioner. Right. So again, these are not numbers of the visits that even our behavioral health numbers. These were just the primary care visits. So not the other data, but what we can do, thank you for saying that, I'll make sure we add an additional slide that will show the total clinic visits and the total utilization. That's an excellent point. So I should have said that this is just the primary care, the actual medical care.
Okay.
Okay.
Can I ask you a question?
Yes, thank you very much.
It's so unusual because it's a largely Hispanic clinic. So there are 2 issues. I agree with you. We all talk about the fact that utilization isn't what it should be, but the challenge.
Stand up so we can hear you a little bit better.
Oh, I'll stand up. Okay.
There we go.
So the challenge with Lake Forest is twofold. One is that it is Hispanic, and a large number of the parents don't speak English. And so the nurse practitioner spends an inordinate amount of time communicating
That
with
too.
parents in addition to seeing the children. And also based on you spend a lot of time communicating with parents because you want them to know whenever you see them because they're not there.
Oh.
The other issue with Lake Forest is space.
Is
Space.
Oh.
The clinic is, they have one exam room, and it's very small, and it's adjacent to the, we call it triage area. And so we've had a lot of discussion. It has over almost 1,000 children in the school. There's no space in the school. And also there's an issue around the ordinance for modular units in Sandy Springs. You can't actually put a modular unit where you can see it from the street. It's part of the state ordinance or whatever. So there's some issues around space and around language. And so that's one of the barriers, but all school-based health centers have some sort of barrier.
Right.
But they're working to improve that, and they've increased their numbers over the past year.
Would one of the barriers be the fact that, and it's I'm saying nothing about immigration one way or the other, that a lot of these parents are not documented, so therefore there's a real fear about coming to the clinic and being seen and.
Well, actually, I don't think that's been a problem.
No, yes.
Going outside the school to be seen.
Right.
Okay.
The schools are more
A safe place.
supportive, safe places for parents, and they have a tendency to want to come.
I mean, do they realize that? I mean, are getting that across to people? Is that what I'm saying? It.
Right, that's one of the strategies.
Okay, to get that across.
Yes, ma'am. That's what they're trying to do.
Okay.
All right, Representative Gardner.
I have 2 questions. The first one has to do with responsibility of the school system. I mean, when you were trying to persuade a school system to put these clinics in, what kind of liability issues do they worry about, and how do you solve that?
For us, there were questions centered around safety, which I mentioned a little bit about where to put the school-based health center, because as Dr. Johnson said, we actually had to utilize space in the school. One of the things that we were real conscious about, though, is making sure we did not take away from academic rooms or space, because obviously kids are there to be educated. So we had to be very creative, again, with space. Some of the other issues is, believe it or not, we had concerns about if a school-based health center was here, would the school be sicker, if you will? Would it see more incidents of communicable diseases and illnesses? So we had to, again, use data and information to dispel that myth that no, actually the population would end up being healthier because we could implement more things and we could see kids quite easily, and that kids who were really sick and needed to go home would be able to be seen or wouldn't be coming back sick. They would actually get the treatment they needed and be well when they came back to school. So safety was a big issue for our board, liability issues. So one of the things that we were real clear about is we have an actual written memorandum of understanding that we spent an enormous amount of time making sure that it dotted all the I's and crossed all the T's. But it is truly, it's a partnership, but we made sure that our MOU through our attorneys, et cetera, is that it functions as its own entity. And the way that we like to see it is if it would be just like any other student at any of our other schools that needed to be referred to a doctor, it's just down the hall. But once they get into the doctor's office, if you will, that becomes between the parent, patient, and that provider.
So you did work out an agreement that
we worked
seems
out
to
a
work.
great agreement. But again, our board made sure that their commitment was the first year we had to pilot it, and we had to demonstrate that everything that we said we were going to do, safety issues, care issues, collaboration, that we demonstrated that. So after the year when we went back to do our first year presentation in 2014, the board approved it, just unanimously and took off the pilot status and gave us permission to open it up again to the siblings, to the kids who would leave there as alumni, et cetera.
That's great.
All right. Ms. Meadows, thank you very much. Thank you for being here. We're running a little bit long. I've got one more presenter, and I do want the people who signed up to have a chance. We've got Dawn Randolph with DIR Consulting.
Good afternoon, and thank you for giving us time to talk with you today about all of these wonderful programs. Let me pull up, and you should have a handout of our PowerPoint. It makes life so much easier to do some descriptors here. I'm Dawn Randolph, and I am the public policy consultant with the Georgia Council on Substance Abuse, and I'm working with a wonderful coalition of folks around substance abuse prevention for kids. And we're so excited to be here to talk to this committee because this is where the kids are in the schools, and these school-based health centers are going to be very critical to what we need. And I'm trying to find there we go, I think. Hold on one second. Nope. Let's see. Yeah, there we go. Thank you. From the beginning. Okay. Just information on our background. Again, what I'm going to talk to you about today is actually how we can help some of the school-based health centers actually have a tool called Expert that will give them some funding. And, that's the thing that, we're hearing. How do we keep some sustainability there? As Dr. Hunt talked about earlier, alcohol, substance use disorders, big issue in the schools. And how do we figure out how to help these school centers find some funding sources? So Expert is a tool that I'm going to walk you through as we go through some background. Again, for those of you that don't know me, actually I live in Representative Douglas's district. I'm in Stockbridge, Georgia, and have been working on substance abuse issues in Georgia for over 2 decades. And I was one of the founding executives for the Georgia Council on Substance Abuse back in 2000. So we're really excited to see there's so much going on right now in the schools. And if we could get to kids early and prevent substance uses, then we create adults that have a healthy future. So let's start with the first slide, because this shows some numbers that aren't as overwhelming as you think. This looks at the big picture. We have over almost 310 million folks in the United States. Actually, 83% of those folks there's no problem. They're not users. They're not addicted. They don't have any substance use issues. We've got some in the middle that are doing harmful use. And then we've got those with untreated or dependent use. And let's break that down to the schools. If you have a school system with 1,000 kids, you've got an opportunity to encourage 830 of those kids who are never going to have problems to keep doing the good things that they're doing. You've got 270 kids 90 kids that need some help. They're on that margin. They're in that middle section. And then you got about 80 kids who are really in trouble. And they're creating trouble for all the kids around them. So how do we get there? How do we help those kids? And I think school-based health clinics are a great opportunity to look at this. And that's why I want to talk to you about Expert. First, let me go a little bit further because I want to be very conscious of your time and talk about the need of kids in Georgia and how we can get them a great future. We know that 1 in 7 or 40 million Americans over the age of 12 have a substance use disorder. And that's more than heart conditions, diabetes, and cancer. 1/3 of all inpatient hospital costs are linked to addiction and risky substance use. And this is a statistic that just gives me chills. 9 out of 10 people with addiction started using substances before they turned 18. So again, this is an opportunity. School-based health centers, how do we help them address this very difficult issue? We're also seeing that people with a drug dependence die at an average age of 22.5 years sooner than those without a diagnosis. So again, I can't emphasize enough, 90% of adults who have an addiction, substance use disorder, started smoking, drinking, or using other drugs before they were 18, and half of those before they were 15. More supporting information here, but when you look around the state, one of the things that we're seeing trending is the heroin and opiate use. Kids are moving from, marijuana was serious, and alcohol is still very high, and drug overdosing from prescription drugs, and then methamphetamines, and now we're seeing heroin. Why is that? Because you, as a legislature, have done a great part in controlling drug prescriptions. I mean, you've got a lot of bills out there, pill mills, cutting on down those. So we keep going to these more very, very scary drugs, and heroin is definitely on the rise. This is another great slide because I can't emphasize enough. If we can catch kids doing good things and those that are at risk, we can reduce their long-time dependence. And schools are the places where we find them. So what are we doing? Georgians for a Healthy Future and the Georgia Council on Substance Abuse have joined together over the last few years, and we are trying to figure out this approach. So we got together with public health folks and schools and all of these different entities and say, if we had a public health approach to really looking at kids where they're at, I think we could break down some barriers. I think we can make a difference, and schools are where they're at. So what we need to do is now give schools the tools they need to make a difference. That's where I want to talk to you about SBIRT. Screening, Brief Intervention, and Referral Treatment is what the acronym stands for. And what it is a multi-dimensional screening tool. It's asking some simple questions through very evidence-based tools about the use of substances. It can even go into depression and anxiety, how they're doing in schools, how they're impacted by peers, and if they're involved in the legal system. It's a really helpful look at what's going on with them and how substance uses are intervening in what they're doing. The BI in SBIRT is called Brief Intervention. And you heard folks mention about health educators here and school nurses. This is a great opportunity as kids are kind of hanging around, waiting for something to happen. What's going on with them? This is a chance to talk about their goals, talk about what's happening in their lives, and do some even cognitive behavioral therapy. You don't necessarily have to be a licensed clinical social worker. We actually had an incredible program at Grady and in Macon hospitals to have health educators in the emergency departments. So when someone's coming in and they're thinking, something's going on here, we need to ask them some questions. This is where they started intervening and saying, wow, this person is using and they just fell off a ladder and broke their leg because of the incidence of that. So now is a great learning opportunity to talk to them because they're receptive. And we found out, as I'm going to show you in some wonderful slides, that when you have them right there, you can either intervene or get them into treatment. And that's what's going to help support their long-term recovery. It's going to move them into thinking about a healthier way of making decisions. So here again is a nice depictor. It just shows you've got screening. You can have it in medical settings, school settings. If there are a no in their questioning, then you reinforce that positive behavior and you say, wow, how are you doing that? What's going on? If there is a yes, then you can ask further questions and assess what's the severity. Is this a high-risk use and we need to do a brief intervention, or is this more severe and we need to refer that person to treatment? Georgia is really poised to disperse SBIRT across the state. We have projects that, both because of Grady and Macon, Dr. Paul Seal, Dr. Gabe Coopermink, Dr. Aaron Johnson, they are doing training projects with pediatricians, with nurse practitioners, with physician's assistants across Georgia. And we're following up to finding out that they can actually do screening and brief intervention as people are sitting there and they're waiting, or they're just, kind of in the middle of things. So now what we have to do is an opportunity to accelerate this by turning on some codes so that these folks can get reimbursed for ESPERT. 3 more slides that I want to show you the difference. In Georgia, the Georgia Basics program, which was, again, piloted in Grady and Macon, they saw a decrease from when the person was first coming into the ER to 6 months follow-up, where they're decreasing their alcohol use, their drugs, their marijuana, and their cocaine. That is pretty incredible. Just talking with them, asking them about their use, not even referring them to treatment, just getting them intervened made a huge difference. We also saw a decrease in binge drinking, and this is a real issue with kids. Kids, go to parties, they're out there tailgating, doing stuff, and all of a sudden they're down in a lot of alcohol. And when you looked at the control group, we absolutely reduced their binge drinking compared to those that did not have any interventions at all. When you think of research, that's really exciting because we're making a huge difference. We also saw an increase in their mental health, and that's an incredible quality of life issue. What is happening is, kids are using for all different reasons, not just peer pressure, not just to experiment, but, again, they're using for a variety, and we need to get to them quickly. And really seeing improvement in their mental health outcome is giving them an opportunity to learn better. And it's giving them an opportunity to grow and an opportunity to succeed in school. There's a lot of words on these next few slides, and you guys, the time is on, and I know the weather's difficult outside. This is background. It's all in your report. In your handout that I gave you is the policy brief that we just released on Thursday called Somebody Finally Asked Me. Everything is in here. It talks about how we can screen kids, and this is a question and answer based approach that school health centers and school nurses are very able to do in their settings. We can intervene with them in a few minute counseling session and really identify how to make a difference and if a referral is needed. We can intervene by reducing their alcohol misuse. A lot of people said, just tell them no. It's like, let's educate them. Let's educate them to see what their future would look like better than if they were using right now. There's also curbing a lot of other types of drugs that is being used by the kids. And for every dollar that we invest, we save $4 in healthcare. So this is a huge preventive cost-benefit approach. And what's even more interesting, for every dollar we invest, we save $7 in law enforcement. So again, getting the kids where they're at and early on. So our recommendation to help the school-based health centers in activating codes called, through ESPERT, they're Medicaid codes that could be used that we know over half of Georgia's youth are enrolled in either Medicaid or Peach Care. And getting these Medicaid codes activated would give these providers the opportunity to bill and really give them the infrastructure that they need. Georgia's only one of 12 states left that don't have the Medicaid codes turned on. And I know Chairman Cooper's thinking, oh my gosh, here we go. Yeah. Yeah. So it's a 4-step process. Identifying the codes, they're CPT codes. 2 of them that are most commonly used are just, again, for brief intervention and referral treatment and screening. I've got all of that information and some data back up there. Defining the providers. We would like to see all the way down to health educators being able to do this, but Medicare guidelines and Medicaid do have doctors and nurses and those kind of folks in the school system that can bill. Number 3 is defining delivery settings. This is, again, it can be in so many places. It can be in federally qualified health centers, school-based health clinics, in pediatricians' offices, all over the place, in emergency departments, and we're seeing some really exciting things happen there. And then finally, defining where we start screening. And unfortunately, it is as young as 12 years old, especially in what these folks were talking about in some of the neighborhoods. These kids, the data is showing us that they're using younger and younger. And we need to catch them doing good early and intervening with them that need help early. Again, I rushed through that because I know the time is late, and I really appreciate you putting me on the agenda because we want to give the school-based health clinics and schools the tool called ESPERT that they need that will, again, give them some sustainable funding, but will also catch these kids very early, either doing the right thing or we can help them make a difference. So I'm going to stop there, and you've got a big packet with lots of information in it.
All right, Ms. Randolph, thank you for being here today.
Thanks.
I think you checked with my office, and we were glad to put you on the agenda for us today. Important information, and I can tell you from an employer base, and I've said this over and over again, the biggest deterrent we've got to a quality workforce in this state is a drug problem. It's not street drugs, it's in the workplace. Employers will tell you over and over and over again, it's the drug problem that we've got as far as quality workforce. So I think it's very important to keep on the front burner, and I hope you'll stay in touch with us throughout the legislative session and bring the initiative back so that perhaps we can move forward with it. Thank you very much.
Yeah, and Senator Renee Unterman has a study committee that she's heading up that we're really deep diving into this.
Good.
But I just didn't want to miss the opportunity because this is linked with schools, and I do appreciate it. Thank you so much.
All right, thank you for being here. We've got 3 that have signed up. Sherry Williams with Georgia Partnership for Telehealth, if Sherry's still here. Right,
I am still here, and good afternoon, and thank you. I know our time and attention are probably running short this afternoon, and these pews are not the most comfortable to sit on, so I will be very, very brief in my comments. I am Sherry Williams. I'm a licensed clinical social worker, and I'm the executive director from Georgia Partnership for Telehealth. I believe you heard a little bit during the last committee meeting about some of the things that we're doing. I just wanted to make a few points based off of what our speaker said today. First of all, Georgia Partnership for Telehealth works in Georgia and globally to reduce health disparities. One of the places we found in Georgia to begin working on this is through our schools. Back in 2009 or 10, I was a part of a team that started Georgia's very first school-based telehealth center down in Berrien County, Nashville, Georgia, way down south. And since then, I am obviously now the executive director for Georgia Partnership for Telehealth, and we're working with 18 counties in Georgia, which covers 77 individual schools, not districts, but school buildings. And we've put together some very successful school-based telehealth programs that are similar to the traditional model you've heard today, but different at the same time. A couple of points I wanted to talk to. Earlier, I heard the question about local providers. We feel that it is paramount to do a local scavenger hunt. We think our local communities, although many are rural and many are very lacking in resources, there's still a lot of stuff happening there. In Berrien County, when we tried this, we did ask our physicians, can you come on campus? Can you provide a nurse practitioner? Can you partner with us? And the answer was no. But when we introduced telemedicine, can you do this via technology? Sure, we'll give it a try. So that has been a great way that we've been able to pull in some of the local resources from our communities to assist our schools and provide care to our students. I cannot agree with Diana Allen more. If you build it, that does not mean they will come knocking down your doors. School-based health in general is a different concept to people. That's not where we typically receive health care. And when you throw technology on top of it, it really becomes this really weird monster. So there is double the education from the telehealth standpoint. From a sustainability standpoint, back in 2012, in Georgia's very first Medicaid telehealth manual, school-based health centers were designated as an approved telemedicine site. It is taking a long time, and we are still not there yet, but hopefully we understand. We've been working with DCH and Dr. Carson very closely, and we understand that in January of 2016, our schools will be able to bill the facility fee and receive some revenue back for the services that they are providing. In addition to the facility fees that can be billed, we feel it's important to partner with our local medical centers. FQHCs, I know, have been discussed today, and they have done a fantastic job. Some of our communities have struggled with that. We have partnered with some of our larger regional medical facilities, and that has seemed to be a very workable plan. And we've seen several schools when the grant funding ends, what do we do next? So they have begun reaching out to their local medical centers, and that has been a fantastic partnership. From a cost standpoint, and I'm not talking about clinic space, I'm not talking about, the paper and pencils to get the clinic, but just from the telemedicine piece, I think the folks earlier have covered the startup costs for a traditional clinic. Telemedicine equipment runs around $12,000. It's not very expensive. And then the connectivity fees annually are about $6,500 per location. So fairly reasonable in terms of cost. The medical services that are provided through the telemedicine services are medical doctors, that are MDs, pediatricians, primary care doctors, psychiatrists, and specialists. We partner heavily with Children's Healthcare of Atlanta, Navicent Health, and Georgia Regents University, and they provide a great deal of primary specialty services that are not available in South Georgia. And folks are driving up and down I-75 3 to 4 hours to come to receive care. So that has been a huge piece to what we've been able to provide in our rural communities. That's all the points I wanted to make today. I wanted to give you a chance to ask questions if you have any. But other than that, I really appreciate you, and I commend the work that you're doing with the study committee.
Sherry, thank you for being here. And I know with our demonstrations on telehealth, it can be an effective tool to broaden access and certainly to connect with specialty providers, especially in behavioral health and some other services that a lot of times there is not local access or even regional access for those. We know that disparity as far as our number of providers. Thank you very much.
Thank you.
All right, and then Jeff Robbins with Tiff Regional Medical Center. If Jeff's still here, he had signed up.
I tell you, I didn't know what to expect, but I did drive 200 miles, so I thought I'm going to take
appreciate
a
you being
chance to say something. But I tell you, the most remarkable part of this was I had no idea what was involved in these very advanced school-based health clinics, and I'm definitely humbled by what I heard, the presentations I heard today. And you made a comment that your giving and your foundation is a spit in the bucket. If you are, you're the Georgia Dome. I'm a thimble. I'm just very impressed. My name is Jeff Robbins, and I am the Director of Telemedicine at Tiff Regional Medical Center in Tifton, Georgia. And I was asked to come down and just give my input on what telemedicine is doing for our community and our end of the state. So I just want to share my thoughts. We have been involved with funding and supporting telemedicine within the school systems for approximately 6 years. We support and fund anyone who asks. If a school asks for a piece of equipment, we give it to them. If they ask for connection fees, we ask GPT to send us the bill. That is a philosophy that we've had for the past 10 years. That's been our entire involvement with telemedicine. We believe it is the school's obligation to keep the student smart, make them smart, and it is our obligation to help make them healthy. And in return, our partnership will give them the best chance in living a full life and achieving all the goals that they should achieve. And we've seen telemedicine work that way. During our history with our school-based healthcare, we have looked into the mid-level model, but we have just decided there is no possible way funding that ourselves we can fund a mid-level. But what we can do is we can fund telemedicine units. We have found that comparing the cost of outfitting an entire school with telemedicine units compared to the cost of a mid-level, historically for us, has just been way too high. So we moved into the direction of utilizing the technology, connecting to a physician. At a much lower cost than a mid-level, we have proven that a school-based health clinic using telemedicine is an effective way to deliver pediatric health care, acute health care to the children during the school day. Again, our objective is to keep the child in the school, not at home. We've seen in our areas, in the end of the state, a child that goes home on a Wednesday usually doesn't come back to school till Monday. We, at times, will see them in our emergency rooms. Most likely, they don't even see a healthcare provider. They come back to school just as sick as they were when they left. And again, a child who is not in front of a teacher is not learning anything. So again, we have found that that works for us. Data from our satisfaction surveys have shown that pediatricians, nurses, parents, and children are finding school-based health clinics that use telehealth as an acceptable alternative to the traditional healthcare delivery system. One provider sitting anywhere within the network can cover a multiple of schools. Today, at Tiff Regional Medical Center, we have 4 employed physicians who are covering our school-based health clinics. They are covering up to 25 schools, and they will also see their daily patient load, but they will cover 25 schools. It could be more than that. It just depends on who calls and uses them. But they are, when they get a call, they stop what they're doing and they see the child in the school. Some of the benefits that we have found over the past 6 years with our limited resources, our support programs present the opportunity to increase a child's access to acute care that many we have found did not have health care until their involvement with telemedicine. Their health care was an emergency room. And that emergency room doctor does a wonderful job on seeing an earache or a broken bone, but he is not concerned about their health, their daily health, their obesity, their diabetes, their hypertension. And we have found that we cannot afford to fix, we have to be able to fix the little 5-year-old because we can't afford when he's 50 and sitting in a dialysis chair. We can't afford that. One of our busiest telemedicine programs is presenting pre- and post-op kidney transplant patients to Emory. And we just cannot afford to have that seat filled 3 times a day, presenting young people who are awaiting kidney transplants. So we believe we have to stop them at a much earlier age. We also, by connecting a child who has already seen a healthcare provider, telehealth within the school enables a specialized provider to review and diagnose a child's acute condition and make recommendations. Probably our biggest utilizer is Children's Hospital of Atlanta, Dr. Goldstein. We personally, in our clinic at our hospital, present probably 600 encounters to her a year. We will supply any school that will connect to behavioral health with a unit. That's just in our mission, and that's what we do. And again, I just touched on that. Maybe the most important and busiest component of our school-based telemedicine programs is access to behavioral health. Behavioral health is what we can't offer in our areas. There just are no specialists like a Dr. Goldstein level physician. We also work with Navicin for GI and endocrinology, which again we do not have in our area. That's really all I want to say.
All right.
Thank you.
Yeah. Okay.
Yes. Yes.
I want to thank you, and this is Tiff.
Tift Regional.
Where is it located?
Tifton County. Tift County.
Okay. Well, you go back to your administration. I chair the health committee, and I hear a lot of whining from the hospitals.
Right.
About just what they can't do and so forth. This is the first time I have ever heard of a hospital who's doing something for one of our schools on health care. I see an awful lot of billboards promoting, their care and this kind of thing, but actually, treating patients in our schools and helping us on that issue, it's the first time. So thank you very much. Please tell your administration I said thank you.
I will. We have an agreement with we have just come to an agreement with 2 schools that are 4.5 hours away from Tift County. The patient will never step foot on our property. We also fund units that refer to Dr. Goldstein that we receive not an ounce of revenue from, but we feel it is so important for these children who need access to these specialists, and it has just been something that we've been pretty much obsessed with over the last 10 years.
Thank you.
Thank you.
Ms. Robbins, thank you very much, and thank your, like Chairman Cooper said, thank your facility for your generosity and taking care of the community, which is very, very important.
Thank you.
Thank you for coming. All right. Taylor?
I just wanted to ask him a question also. I wondered, how is it paid for? Are these doctors hospital employees? How are they compensated? Their staff?
All of our physicians that take telemedicine call are employees, and they treat it like any other patient that they would see. They treat it as a work-in.
Okay, I just have to tell you, it is wonderful. I am from South Georgia, so really appreciate how well this is going.
We also have doctors that see patients in orphanages in Afghanistan and Guatemala on a regular basis. Every Tuesday at 1 o'clock, we have a doctor who sits on and sees patients from Guatemala, and that is free of charge. Afghanistan is obviously free of charge. These are just men and women who feel that this is a calling in their life, and they feel that this should be done. So when there's an opportunity for them to see a patient, they just say, "Tell me when to get on the camera, Jeff."
Thank you so much.
Thank you very much. Representative Gardner.
I just wanted to ask quickly
About Dr. Goldstein and the need for psychiatric referrals. I know that she is employed by CHOA.
Right.
Is that the only behavioral health resource that you have?
That is, well, we have other resources, but that is who we utilize for our autism clinic. That is our main source. There are days where our entire day is presenting to Dr. Goldstein. 10 encounters and up on a certain day.
So I'd like to hear some about your other sources and sort of how the cost. I mean, have you put together some figures to show how much the equipment costs and how much per kid? And
Yes, my budget this year will probably be. We haven't got our budgets yet, but it'll come in probably around $250,000. And our return on the investment is the people that we are helping.
Yeah. Do you have numbers on a chart somewhere?
I do, but I don't have them on me. This was put together quickly.
I'll get together with you later.
Yes, and again, our return on investment is the impact we're making in people's lives.
Huge. It's wonderful.
Yeah.
Thank you.
Question?
Sure.
Will the administration let you come back up and testify before my committee when you have more time as someone who's doing the right thing in their community and not whining about how bad off they are? And that's my part. You don't have to say that, but anyway.
I don't even need to ask. Of course I will.
Thank you very much.
We will invite you back.
We'll invite you back.
Thank you, Mr. Robbins. Thank you very much. Anyone else on the committee? We're pretty well going to sum up. Becky? Becky Riles.
Thank you, Mr. Chairman, members of the committee. I'm Becky Riles, and I am contract counsel for the Georgia Association for Primary Health Care. And what I'd like to do very briefly is try to tie a ribbon around what you've heard about community health centers, and particularly the school-based health clinics. The community health centers that you heard about and from today are 4 of 34 organizations around the state. Aren't you glad the chairman didn't invite the other 32%? Each of them are equally unique. They are all 501c3 nonprofit organizations with locally governed boards of directors. And I would also like to mention that 51% of the board members for each organization are patients of the community health center of which they serve. Yep. So 34 organizations, community health centers are currently in 107 counties and 197 clinical sites across our state. The Primary Care Association serves as the member association for all the community health centers, providing technical assistance, IT assistance, development work across the state to try and fill the gaps that may exist in areas that are still underserved. Most, if not all, of the community health centers in Georgia are currently credentialed or in the process of being credentialed as patient-centered medical homes. And I'd just like to reiterate what you heard from the presenters, that the goal of a community health center is to fill an unmet need. It is not to compete with any other provider, but to fill the gap for those children, as it relates to school-based clinics, siblings, parents who currently do not have a medical home, do not see a medical provider until they show up in a dental chair in a mobile unit at 16 years of age for the first time seeing a dentist. So that's the goal of a community health center. And they do yeoman's work, as you've heard, in referring that patient back to their medical home if they have one, and also providing the medical records and detailing the care that they received at that school-based clinic. I wanted to address just a couple things that came up and each of you had questions about. One, the PPS rate. The prospective payment system is very comparable to the prospective payment system that rural hospitals receive, that critical access hospitals receive, as a way to try and provide a foundation for these safety net providers who provide access points for individuals who otherwise would not receive the care that they need. The PPS rate is important because it does allow them to provide the other services that you heard, the nutrition counseling, the caseworkers, the behavioral health services, and the other myriad of services that community health centers provide. Supervision, Madam Chair. I heard your question loud and clear and want you to know that community health centers, the mid-levels who are employees of community health centers, are some of the most closely supervised mid-levels in our state. And not only because of the legal requirements, but because of the quality metrics that they're required to report to the state and to the feds, because of the federal grant money that they receive, but also because of their commitment to quality outcomes. And they're not satisfied unless they are at 100% of women in their community health center who receive mammography. They're not satisfied until the screenings for each of the patients is appropriate to their gender and age are fulfilled at 100%. 340B, I'm sorry that Representative Hardin had to leave, but I do want you to know that that is an example of what the State Association does on behalf of all of its members, is work very hard to keep the drug pricing, particularly as it relates to the 340B program, at levels that allow us to be able to provide those medications to the patients who need them, in some cases at no cost or a minimal cost. And finally, Representative Taylor, it is rare, but there is, on occasion, an insurance company who will push back about community health centers. It's typically just because they are not familiar with community health centers. And once they get to know us and get to know the services that we provide, they recognize the quality that is there. So in closing, just thank you for the time to speak to you today. Thank you for the beautiful program that you put forth on your agenda, Mr. Chairman. And I'll provide a map for each of you so that you can see the areas that are currently served by community health centers, not only for your constituents, but all the citizens of Georgia.
Okay. Thank you, Becky.
Thank you.
Thank you for your representation. We're going to finish up here. We are way over. I'm sorry to take so long. We were trying to stay within 2 hours. Any comments or questions from the committee? For additional comments. I think today what we have found, as far as a summary of our key points, is we've seen how frameworks work, and it just reinforcing the fact that these have to boil up from within the community. It has to be a community effort to move forward, and that there are resources out there, and that we get a tremendous return on investment for this. I hope that our final report is going to sort of be a blueprint for representatives that they might be able to take back to their community to start the conversation about improving the health in their community, especially with their children. And I appreciate the panel's, the committee members' participation today. Appreciate you being here. One other thing, if we had one other meeting, it might be a site visit, and we're getting close in November with Thanksgiving and the holidays and so forth. Is there a sentiment that Demetrius has visited the site, or would we like to do that on our own? And then in the different areas, and then if you want to just, okay, we can just, and if you could, just in your own words, just make a summary of what you saw, and something about organization and structure, because I think that's the key point that we want to give as far as our report, and being able to create a blueprint that can be replicated across the. Okay. Okay, that'd be great. Thank you. Thank you. All righty. With that, we'll stand adjourned. Thanks for everybody's participation. Dr. Johnson, thanks for being here today.